thank you for joining us today. Maureen has got up extremely bright and early. She is in Boston, and it's wonderful to have the chance to talk about a topic that we are passionate about. And I first met Maureen when I was a fellow at the IHI in 2005. And really the work that we're going to describe goes back to then. And I would say that it wasn't terribly fashionable then. And I think now, I hope it isn't fashionable. I hope it's much more mainstream. And I hope by the end of today, we will have given you a little bit more inspiration and also some practical tips that you can take into your workplaces wherever you are. As Maureen says, as Laura said, we want this to be interactive, so please chat in questions and comments, and I'm going to get you to do a poll in a minute. But Maureen and Gill, please just say hello and tell us why it matters to you, this topic of getting rid of waste. Let's go to Maureen first.
Thanks, James. I have cared very deeply about this topic, as James said, for many years, but it started when I was a very young CEO, 34 years old. In my first week as a CEO of a hospital, I was looking at my quality data, and I'm embarrassed to say now that our hospital was a little bit better than the national average. And I thought, well, we're a little bit better than the average. So I was satisfied. The next thing I looked at after the quality data one day was an article written by Brent James, and he was talking about central line infections. His rate at Intermountain Healthcare was 1/10 of mine. And I was shocked at how I could feel satisfied 1 minute at a little better than the national average and horrified the next minute that someone else was so much better. So I called him and I said, you don't know me, but help me understand how do I get my infection rates to be like yours? And he coached me through. But the first thing I did was I called the chief medical officer and I said, let's go visit someone who has a central line infection. We went and I met a woman who told me she came in for a very brief procedure, had been in for a week, showed me her arms with all the black and blues and infiltrates and how the infection happened. And then at the end, she said to me, last night, I missed my daughter's wedding rehearsal. And if I miss her wedding, I'm going to be mad at you. And that went right to my heart. Here we have this infection. So we went up to the chief financial officer and I said to him, when we infect someone as opposed to doing it normally, how much more does that cost? And he said, oh, we don't do it on purpose. But the day that she told me about missing the wedding rehearsal and the day that he told me how much money it cost us when we infected somebody was the day that I began to care deeply about waste.
Wow. Maureen, there's a lot there. Thank you. Gill, over to you.
I suppose I came to this topic probably about 4.5 years ago through my involvement with the Health Improvement Alliance Europe. And I remember Maureen standing up at one of our meetings in London and talking about the work that the US Leadership Alliance were doing and feeling that this was something that we could get engaged with. And then actually that lined up with something that was happening in my own organisation. So we had done a great deal of work on end-of-life care pathway. And we were really starting to see the benefits of that. And the patient experience, family experience, data coming back was so powerful. But yet we were really struggling to get any scale and spread on that. And when I talked to our palliative care lead, I realised that she just didn't know how to negotiate the way through the system. But yet, when we looked at the data, what we could see was that the patients who were experiencing that pathway were having 2.5 days less length of stay in hospital than those who were not, 50% less ED attendances, and actually organisationally we were reducing costs by around 50%. So for me that just spoke to time is such an important thing when somebody is in a palliative phase of their life, and we need to give that back, not take it away. And we could bring something to the organisation from an organisational point of view with a cost reduction and reducing someone's presentations to ED. It just seemed like a no-brainer for me. So in the segment of presentation I'm going to do here, I'll talk a little bit more about that. But that was my motivation.
Well, thank you very much, Gill. Both of those really chime with me. My brief take on this is that when you talk to staff, It doesn't matter where they work in healthcare. They could work in a hospital, they could be in a clinical or a non-clinical role. And also patients, we've all had letters, we've all had visits that were mistimed or not ready to happen. So anyone associated with healthcare, they know that the waste is all around, and the staff are bound by it. They feel that their feet, one nurse said to me, I feel like I've got treacle around my ankles and some days up to my knees. And so for me, it's about taking those shackles off. And I think a really important thing is the distinction between the role of leaders in helping remove that waste, helping see it and go after it, and the worry that many of us have about using the word waste, that there's an implication that we'll say you are wasteful, which is really the very opposite of what we intend. So thank you, Maureen and Gill, for those perspectives as we get going. I just want to acknowledge an absent colleague who is currently at a graduation for her Generation Q programme, and that's our colleague from IHI, Susan Hanna. So Susan, I hope you catch up on this. As you know, this show wouldn't be on the road without you. So I'm going to just set the scene here. We want to go to get some input from you through a poll online, and there is going to appear very rapidly in your chat box a link to a Menti poll. Associated with the technology, there's a bit of a delay, so I'm just going to read you the questions that are going to appear for you in two separate polls, and then I'd like you to click on your link. You'll be taken to Menti and then move from one question to the next. But the first question is really to get your views on how much waste there is. What's the scale of the problem we're talking about? So the first question is, if you invested, we've gone for dollars because we didn't want to speak to any particular currency. So we'll go with the default global currency. If you invested $1 million today in healthcare, what proportion of that do you think would be waste, would make little or no contribution to useful outcomes? And then you have a choice between 2% if you're at the low end, or more than 30% if you're at the high end. And then the second question is about really thinking about, as we have done and as you've been chatting in, what does the term waste mean and speak to you? And you can pick as many as you believe relevant from 6 options. And if you think there are things missing, then please chat those in. So hopefully by now, we will have dealt with the time delay on the platform. And Kyle, can we switch over to the poll and to see the results building? Fantastic. So, okay. As ever with these things, they move as you're talking to them. But I guess I'm not surprised that most of you are on the high end. We've got this curve skewing to the right. I guess I'd be particularly interested, perhaps in discussion at the end, to hear from people who are at the lower end, because you've decided to come to this session. But most of us think that this is a pretty big deal. So a quarter or a fifth at least or more. Excellent. Thank you for that. Kyle, can you go perhaps now to the next poll? So let's watch this one building. Whenever anyone clicks a response, a little blue circle flies in. And don't forget, you can click as many of these as you think applies. Laura, I can't see the chat in real time. Is there anything in the chat that speaks around these themes?
Nothing so far is coming up, but please do, if you have reflections on what you're seeing here, pop those in the chat and we'll come to them.
Okay, thank you. So to comment on what we're seeing, I'm glad that there's a coin has gone in the patient time aspect. Some of you will know Brian Donlan, who's a wonderful nurse academic leader. I think he's spent the pandemic in New Zealand, but he describes his purpose in life. His professional purpose is reducing the waste of patients' time. And if we in the UK, we have 4 national health services, 1 for each country. And I often think if we added up the amount of time for Scotland PLC or Wales PLC that we waste in terms of patients' time just by not getting things right, and that's one of the really important forms of waste. Okay, so unnecessary steps and unnecessary admissions and stays are the 2 dominant areas coming through in that poll, and we will come to those through the conversation to follow. So thank you very much for that. Keep your thoughts and questions coming in the chat. And now, Maureen, over to you to give us some conceptual framework around this. Thank you.
Thanks, James. And I think what I will have to say does actually build on what the audience is saying is important. There's a lot of ways to think about waste. And as James said, in the beginning, we thought we needed another word. We were a little bit afraid of using that term. But what we found is when we talked to doctors and nurses and therapists around the world, they said, we see waste every single day. We want your help in removing it. So I think there's a lot of energy right now. The one thing I would say that is the wrong way to approach this is to just say we need to save money. We're going to do an across-the-board cost cutting. That ends up with decreasing quality. But when you think about where the variation is, when you think about where the unwanted energy goes, then people will join in and want to help you reduce waste. One example from Boston here in Massachusetts is looking at the variation between CT orders by different members of the staff. You can see incredible variation, and most oftentimes the most experienced physicians order fewer CT scans in the ED because they really understand better, I think, how to assess the patient's needs. So I think there is a way for us to think about a positive approach to this. What we're seeing is if there is strategic, targeted waste reduction and focusing on getting rid of what adds no value, and as James said, it's no value to patients, like an unnecessary CT scan, but it's no value to staff as well. It's the time and energy they expend in a day when they're adding no value because our processes are poor. Raise joy in work. When we focus on eliminating the stuff that's adding no value to staff, we find that we're respecting them, respecting their time and energy, and actually increasing their joy in work. And when we co-produce care, health and care with patients and families, they'll often tell us, if we ask them what matters to you, they're very clear on what they perceive as value. And so asking that question to leaders, is this adding value to your system? Is it producing better clinical outcomes at a lower cost? Asking staff and asking patients is producing a triangle that I think gives us a path forward on waste reduction. If you haven't read this book, Compassionomics, I would highly recommend it. It's by 2 physicians from here in the United States that are talking about how compassion and economics really come together. And oftentimes, if we just say we're going to do an across-the-board 5% cost cutting, you take the compassion right out of the system. But when you actually focus on putting compassion in, it's amazing to see the results. As an example, in this book, they describe when an anesthesiologist comes out of the pre-op room and meets the patient before they're wheeled into the operating room. The anesthesiologist comes out, places his or her hand on the patient's arm and says, "My name is Maureen, I'm going to be with you for the whole surgery procedure. I'll make sure you are never uncomfortable and you don't have pain, and I'll bring you right back to the post-recovery. Everything's going to be okay. I'm with you. That 40 seconds of compassion has reduced the amount of anesthesia the patients use in the operating room, reduced the amount of pain medication they take post-op, and reduced the length of stay. So we can reduce cost by introducing compassion. It may seem counterintuitive, but all three of us here believe very strongly in that. So as Gill was saying, in the United States, we have a leadership alliance that began to count where is the waste in the system. And in the United States, they found $1 trillion worth of waste potential. These are major organizations from across the country that get together regularly, and they're focused on where was the $1 trillion. They found it. It represents about a third of the expenditure, almost a third of the expenditure of healthcare in the U.S. And they categorized it this way. So I included this so that you can see how people here are defining waste, because this then allows leaders to charter up improvement projects based on these. And you can see that you're improving quality of care at the same time you're taking waste out of the system. So I wanted to give you 3 tools today that I think are really important. The first is innovation. If you specifically build new models of care, we find you can produce much better clinical results at a lower cost. And then we need to spread those to assure that the innovative models of care are reliably spread to every single patient, every single unit in a hospital, or every single clinic in an ambulatory setting. So it's innovation, new models, and we're finding all over the world some really inspiring new models of care. You've learned a lot about them here at the forum, and you'll continue to learn about them as we stay together. Spread, I think every hospital needs a head of spread. Somebody has got to make sure that every unit benefits from the innovative models that are created. And the third thing is exnovation. You might not have heard that word, but it means purposefully getting rid of all the unnecessary junk in our lives. My husband says I'm terrible at exnovating my closet, but I'm very good at exnovating in healthcare, because I can now see that we very rarely actually get rid of things that don't add value anymore. In healthcare, if you walk onto a unit and open a closet, you can often find old forms, old tubings that don't fit into anything anymore, just in case. We save things just in case. But exnovation is a purposeful process for getting rid of what adds no value. Another process that we're seeing has really been helpful is deprescribing, that on a regular basis, people are taking a look at all the meds a patient is taking and specifically looking at which ones are adding no value. In the United States, as an example, many patients will see 3, 4, 5 physicians in the course of a year, and they tend to prescribe, but nobody tends to deprescribe. So there are now processes where once a month for elderly patients, a pharmacist will do a FaceTime visit, and the person will lay all their medications out in front, and they'll have a conversation about what's working, what isn't, what may be reacting together. And then they're deprescribing and helping all of the physicians to see that they've got to come together as a team to make this better. And then innovation, just one example is from there in England. What we're seeing there is looking at how do we change a process to produce better clinical outcomes. As you probably know, muscle loss when a patient is bedridden is somewhere around 11 to 12% per week. So keeping somebody in a bed is automatically extending their length of stay and making their care prolonged, because we're actually taking away muscle loss as we're trying to make them better. So, it just is like the old way. Put somebody in a bed, we'll come in, we'll take care of you. The new way, several hospitals in the east of England said, we're going to end that muscle loss. We're going to end PJ paralysis. So all of the staff actually wore their pajamas to work one day. And they said, this is the end of PJ paralysis. We'll wear our pajamas one more day, but then we're going to get you out of bed. And in doing so, what they found is that the patients are mobilized, they're not losing muscle mass, their lengths of stay are shorter, and the patients are really taking more of a sense of control. So it's a way to look at the length of stay as waste if you keep somebody in bed and cause muscle loss. So it's an example, I think, of an innovation that started with some people saying, why are we doing this? Is there a better way? How do we motivate a campaign? Let's all wear our pajamas to work one day. And then, as you can see, the spread across the system has been deliberate and effective. So last time I looked, there was about 91,728 days that were returned to patients' lives by having that reduction in muscle loss. Whoever would have declared muscle loss a categorization of waste? But when you start to look at waste in all the categories, your eyes will be opened to all these new ways to think. So over to you, Gill, to continue our journey.
I have spoken a little about what motivated me to get involved in looking more seriously at reducing waste to add value in healthcare. I want to now delve deeper into my waste journey over the last few years through my association with the IHI Facilitated Health Improvement Alliance Europe. The startling revelation that 1/5 of health expenditure makes little contribution to good health outcomes is surely a call to action to tackle waste. A significant share of healthcare spending and activities are wasteful at best and harmful to our health at worst. Combine this with the global challenge of healthcare financial constraints, ageing population and the burden of chronic disease, and more and faster is not the answer. A new approach is needed. In order to optimise health system performance, the Institute of Healthcare Improvement offers the triple aim: improving the experience of care and health of our populations at the same time as lowering per capita costs. A focus on what matters, informed by the What Matters to You movement, encourages us to seek out that golden triangle of waste through which we can target waste reduction, focus on value, and enable this through co-production. So what do we mean by waste? The evidence of waste in healthcare is indisputable, and now it's time to act. But how? The term waste is often incomparable to those of us in healthcare, as somehow it seems to undermine the purity of purpose, making services safer and better for patients. However, when we frame that term into meaningful components to caregivers, it becomes a reality, something identifiable. Recent work facilitated by the IHI American and European Healthcare Alliances demonstrate that when the evidence of wasteful impact is well presented, it's a strong motivator for change. What does waste look like? Waste, or muda, as the Japanese refer to it, comes in many forms. The concept of muda encourages us in the Alliance to think beyond euros and pounds and to consider waste in the form of delays, rework, overproduction, movement, defects, and the waste of spirit or skill. These concepts are well articulated by research which highlight three prominent examples of waste of health resources: unnecessary attendances, inefficient processes, delays in discharging patients. So how is it possible to create a model to capture, quantify, and share learning and data on adding value and reducing waste in healthcare? The first step in my journey was working with colleagues from across Europe as part of the Health Improvement Alliance Europe and adopting the definition of waste developed by the IHI Leadership Alliance in the US. Resources expended in money, time, and/or personnel that do not add value for the patient, family, or community. The next step in the journey was to articulate the scale of the problem and develop a theory of change. The $1 trillion checkbook developed by the Leadership Alliance in the US offers examples of opportunities to reduce waste and cost. It allows for a practical conversation on how we might invest these dollars into better health and care. The work of the US Alliance in the development of the $1 trillion checkbook estimated that $6.2 billion alone could be paid back, associated with preventable hospital infections, and that's only one area. The Leadership Alliance framed their aim of systematically and proactively identifying and eliminating 50% of non-value-added waste in the US healthcare system by 2025. A theory of change is presented in the form of a driver diagram. Together, the driver diagram and the checkbook create the strategic framework for removing non-value-added waste. There are 7 primary drivers linked to a series of practical and doable actions directed at achieving this aim. In late 2018, the Health Improvement Alliance Europe committed to apply the Leadership Alliance framework to the context of healthcare in Europe, operating on the understanding that waste reduction approach is fundamentally different to arbitrary cost cutting. We are unifying people by making clear the negative impact of waste on staff, patients, families, and demonstrating the powerful impact of reinvesting the savings to design and spread innovative models for better health and care. A key step in the journey was framing waste in a way which is relatable to health and care staff, uniting caregivers in the cause. The issue of time as an important currency emerged as a very strong theme, and Maureen referenced this earlier when she reflected upon the PJ Paralysis campaign. The importance of not wasting patient time through waiting for results or unnecessary interventions, in addition to maximising the use of staff time by appropriate deployment of skills and resources to effective interventions, is key. Alliance members learned that healthcare staff did connect with the term waste when illustrated by practical example and using engaging communication methods. Images are powerful. During 2019, members continued to progress discussion on waste in their own organisations, and in my organisation, the Northern Health and Social Care Trust in Northern Ireland, we developed a set of engaging infographics to communicate the power of the message through the eyes of the system, services and patients. As an alliance, we produced this powerful illustration which draws out the frustrations that healthcare staff feel when they experience waste, and also to illustrate the benefits that can be derived from eliminating it and some tips on how to address waste. The examples from my own organisation include the impact of suboptimal use of medicines as a contributory factor to avoidable hospital admissions and adverse incidents. The evidence indicates that pharmacy teams can reduce patient length of stay by 2 days and readmission within 30 days by 10%, avoiding a cost of around £825 per patient. Through an end-of-life care pathway, those patients experience fewer hospital admissions, a 2.2 reduced length of stay and a lower presentation rate at ED. The cost of their care is 50% less than those patients without access to an end-of-life care model. Since late 2018, the waste journey of the Alliance has matured. The language has become less alien and the concept of waste in healthcare is better understood. The learning illustrates that by socialising the language and using infographics and illustrations to demonstrate waste, staff and patients bring the concept to life with practical work. We all know that images are more powerful than words, and as our journey progressed, we found ourselves in a rapidly changing world, shaped by COVID-19, presenting us with many new challenges, not least how to provide services differently. The pandemic has more recently presented us with the opportunity to build upon this approach. In response to COVID, we have seen rapid cycles of change to adapt to new challenges and provide appropriate response in changing circumstances. Process improvement and learning gathered answers to the question, did we remove waste in providing healthcare differently in our response, and in doing so, have we created opportunities for innovation? COVID-19 Wave 1 learning in my organisation demonstrated 4 categories of changes associated with Exnovate to innovate. Virtual and home care working, communications and technology enabling new ways of working, predictive data to drive decision making, and new service models prototyped which are now established. The learning has also quantified the impact in terms of organisational benefit, staff benefit and environmental benefit. How were those Exnovation opportunities surfaced in our learning? Through a review of around 120 interventions tested during our COVID response, using the model for improvement, examples of Exnovation were drawn. At the time of response, not all the data related to the change was captured, so in many cases this has been a retrospective exercise. Our theory for change for this work was presented in the form of a driver diagram. Our analysis at Northern Trust demonstrated that we have the capability to free up over 24,000 hours in staff time through reducing travel, through remote working. The benefits to this are also financial and environmental, with around 1.2 million travel costs avoided and 685,581 CO2 emissions avoided. That's 29,000 recycling bags of rubbish to landfill avoided. New service models like our emergency surgical unit are also providing a reduction in length of stay for surgical patients, avoiding nearly 6,000 bed days per annum. These are just a few of the opportunities that exist when you exnovate to innovate. So in this journey, spanning the last 3 years in my organisation and through collaboration with the Health Improvement Alliance Europe, what I have learned is that it is possible to apply a new framework for waste reduction in healthcare that surfaces areas for opportunities to add value. Furthermore, the term waste is meaningful to healthcare staff when articulated in a manner which brings reality to concept. Responses from healthcare staff to the example surface demonstrate opportunities to unite in the cause of adding value and reducing waste, and encourages participation at all levels to remove waste for the benefit of the system and, most importantly, to our staff and our patients. Moreover, the challenges presented in response to the pandemic have increased opportunities to exnovate and innovate, and previous modest investments in digital healthcare and transformation are now paying off. It is important that we complete the swing and do not allow a return to the way things were. The best of the innovations that have surfaced during the pandemic response need to be hardwired for the future. We have an opportunity to continue the journey of exnovate to innovate, articulating the impact of changes through data and practical examples, and then perhaps we just might take the next steps of paying back those green dollars. As part of my Trust response to reset and rebuild, we have taken the learning from COVID of those exnovation opportunities and assessed their potential for scale-up organisationally. In addition to the earlier examples I shared, other scalable interventions include the development of our gynae assessment unit, facilitating more timely triage and treatment of women and avoiding unnecessary admissions, delivering a projected annual cost avoidance and are saving us around 4 beds per annum. By moving and applying a blended approach to virtual and in-person recruitment, we have also the opportunity to free up travel time for candidates and avoid significant costs and environmental impacts associated with the same. Opportunities for exnovation and innovation come in all shapes and forms. Exnovation can also take on a systems approach. Across the country in Northern Ireland, all of the 6 health and social care trusts have embarked upon collaborative work to scale up opportunities for learning and exnovation associated with 3 key aspects of service change in our COVID-19 response. That is related to virtual visiting, virtual consultations, and staff health and well-being. Our work is underpinned by our theory of change, supported through measurement and facilitated across the region by regular share and learn virtual sessions. This work is a demonstration of learning, collaboration and scale up at a health and social care system level, presenting us with opportunities to realise benefits for our organisations, the staff who work in them, and importantly our patients. It's also a demonstration that adding value, reducing waste and exnovate to innovate are not abstract or theoretical terms, but can be brought to life through the application of improvement science and systems thinking. So what can you do to bring about those exnovation opportunities and help pay back those dollars to benefit our patients? We need you.
Thank you very much, Gill. You said that a picture speaks 1,000 words, and that's true, but there were some pretty powerful words there as well. I'm hoping that one of your pictures is going to come back up here, which is the one of the surfer. It doesn't seem to be coming up, but my daughter, that's the one. My daughter is 9, and she has recently joined the eco team at school. And perhaps hers is the generation that's finally going to clear this up, this mess that our generation has created. This is a reprise of one of the pictures that speaks 1,000 words that Gill has. But we just want to bring us home really by focusing on what the NHS in England is doing. And there's a report. I seem every time I touch the slide button, it seems to move 2 slides, which is slightly problematic. But there's a report from which this is taken, which is entitled "Delivering a Net Zero NHS." And you can see the green logo, and that's quite significant symbolically, because one thing I've learned working for over a dozen years in the English NHS is you cannot tamper with the NHS logo. So this is the only thing I have ever seen which is a variant of the logo, which speaks, I think, to the importance attached to this. So the UK is hosting the COP26 Climate Accord in Glasgow later this year, and out of the Paris round a few years ago, the NHS in England really picked up this idea that green healthcare is better, and that the NHS needs to make its contribution. So in an advanced economy, perhaps a bit lower in the UK than in many countries. In the US, it's about 18%, but in the UK, it's around 10%, low teens for most countries, share of the economy, which is healthcare. And of course, that generates a disproportionate amount of carbon because of the things we do in healthcare. And so you can see on this picture, there are 2 slices to this. On the pie chart on the top, the left-hand segment from 8 o'clock around to midday is the direct contribution of healthcare activities. We have 1,300,000 staff working in the English NHS. So their travel, for example, is a substantial amount of carbon, unless they're walking or biking to work. But an even greater share is the indirect, the footprint plus, from things in equipment and the supply chain. And if you look on the right side of this chart, the size of the circle is indicative of the size of the prize to go for. And I'd encourage you to take a look at that report. It's very readily available, Googleable, online. But what you'll see is that it's by and large the acute sector which is responsible, not surprisingly, for most of the carbon. That's where the high-end stuff, the consumables, the single-use stuff takes place. Notable also around medicines and chemicals in primary care. But think about the importance here, echoing much of what Maureen and Gill said and some things in the chat. Think about the importance here of good care being timely and keeping people to the left in that chain from prevention through early phases of disease. Avoidable hospital admissions carries a huge price. So the point here, I think, is not just that Elizabeth is going to have a better chance of a planet to live on that's livable if we get this right in healthcare as an industry, but that better care is cheaper, as we've heard from Maureen, and better care is greener. So this net zero team is really working on the same things that we are in the improvement directorate around improving pathways of care. I have another chart which I don't seem, oh, here it is. So this shows you the impact of inequality on those acute admissions. And what the chart shows, this is data from London, but you are 2.5 times more likely to be admitted to hospital for an acute illness if you're in the least wealthy, the most deprived segment, than in the least deprived segment of our population. So think about not only the issues around care for that individual, which is enough, but think about the time and the cost and the rework and the carbon coming out of that for the planet. So, Gill, over to you to bring us home, and you've got a final poll.
We have, James. We have a final question for everybody, and maybe the reflections of what we've talked about might give people a bit of food for thought on this. So hopefully the question is appearing in the chat as we speak, Laura. But what we want you to think about is, if you could invest the $1 million returned by waste reduction efforts, where would you send it? So would you bring that back into the workforce? We heard a lot about workforce frustrations and teams feeling like they're walking a treacle. Would you invest it in the health prevention work, so getting upstream early? Or would you direct it at technology? And we've seen many great examples over our COVID response and how technology has enabled us to do things differently and actually exnovate and innovate. So those are the three choices. Hopefully we might have some early responses shortly. Great. Okay, so interesting. And I know the numbers will probably move around a little bit here, but isn't it interesting? We're all wanting to get upstream and invest in the health prevention work, because we know that's where we have the greatest chance of making the biggest impact. And closely following behind that is our workforce. And I think, again, our experience over the last 18 months in COVID has taught us a lot about what we need to do to invest in that workforce. So getting upstream, that's what we need to do. I am going to move us to our last slide, I think, and then we are going to have a little bit of time for some questions. So I suppose I just wanted to reflect a little on some of the things that we heard during the conversation this morning. We're suggesting you get your Muda glasses on. So for those of you who didn't quite catch what Muda was, it's the Japanese word for waste, and I referenced 6 types of waste in my little pecha earlier around the types of things that you might think about. But it is about thinking of new ways to see work. And Maureen encouraged us all to think about those new models. It's new ways to see teams. And actually, as Maureen also referenced, everyone should have the opportunity to get involved in innovation and benefit from that, because everybody wins. The patient wins, the staff win, the organisation wins. And then there's new ways to see co-production. So really, if we want to be very intentional and purposeful about changing the dynamic and how we manage this issue of waste, we need to do it in a co-productive way. We need to go back to that golden circle, and we need to involve our service users and our patients in doing that.